about the burden of breast cancer, and then we'll move on to some of the vocabulary that we use so that it'll be easier for you to follow my talk. And then we'll move on to how we take care of patients with early stage breast cancer and locally advanced breast cancer, and how and what kind of tools we have in our ability to prognosticate and predict for treatment in the management of these patients. The burden of breast cancer, it's among the leading causes of cancer deaths globally. And to understand the burden of breast cancer in the US, 1 in 8 women who live today will have breast cancer during their lifetime. And 30% of all cancer cases newly diagnosed in women are breast cancer. So substantial chunk of cancer diagnosis and cancer deaths from breast cancer. In fact, it is the leading cause of cancer in women in majority of the countries, with the exception of sub-Saharan African countries, where cervical cancer actually predominate. Some of the vocabulary that you need to know to follow my talk and to understand how we treat breast cancer patients. In terms of staging, it's very important for us to know how we stage breast cancer. And one of the components we use for staging is something called tumor staging, or T staging. And it's basically depending on the size of the tumor. T1 being a tumor of less than 2 centimeter size, T2 between 2 and 5 centimeter size lesion, and T3 above that, and T4 when you have all these things on the breast itself coming out of the breast, like a skin lesion, an ulcer, or involvement of the muscle, as shown in the T4A slide set there. In terms of nodal stage, that's the other component we use in understanding the stage of breast cancer. This is all the various nodes surrounding the breast where the cancer cell can run up to. And depending on where and how many and to what extent of these lymph nodes have cancer, we define the nodal stage, which can be N1, N2, N3, and the like. And together, taking together T and the N stage, we sort of determine the stage of cancer. Stage 1, 2, and 3 are considered the early stage and locally advanced, and stage 4 are considered metastatic, where cancer is actually out of the nodes, out of the breast, and is actually hiding or is present in a visceral organ like a liver, lungs, or bones. So that's called metastatic disease. Another important aspect we need to understand is the tumor subtypes. When breast cancer was first identified over the last 50 years, we didn't really know much about it. But later, over the last 40 years or so, we've sort of figured out there are different types of breast cancer. Initially, these were decided based on the expression of estrogen receptor and progesterone receptor, that's the ER and the PR, and the expression of HER2 receptor, that's the human epidermal growth factor receptor. But later on, investigators broadly defined these breast cancers based on some subtyping. And those subtypes imply the ability of the tumor to grow fast or to be indolent, slower growing. Luminal A-like is when you have too much of ER and PR expression, that's the estrogen receptor expression, and low-grade tumors. These are tumors that are very indolent. I see a lot of patients in my clinic who had the breast cancer because of the fact that they were taking estrogen replacement when they are older, 60 and above, for instance, and they get some breast cancer. And when you see those patients with breast cancer, they're very slow growing, very, very slow growing. It doesn't cause any problems to the patient. Even if it's metastatic, you can easily suppress it. And whereas I get some patients, especially younger women in practice, at the bottom of the spectrum, where these cancers do not express estrogen or progesterone or HER2, and these are very fast growing, and these are sort of broadly called as basal-like. And in these women, the cancer grows very fast, as is noted by the grade of the tumor or the Ki-67, that's the proliferation marker. These are more aggressive kinds of cancers. So on a broad range, these are subtyped based on luminal A, which are the indolent ones, luminal B, which are slightly more highly proliferating. HER2-like is where you see a lot of women with breast cancers that are HER2 enriched. A lot of HER2 expression on the cell surface. And basal-like when you basically do not have these expression. Now coming to management of the early stage breast cancer, in the yesteryears, we initially do the surgery if patients have early stage or locally advanced breast cancer. And then we do not know if these women have hidden micrometastatic cancer cells. Okay? At the time of diagnosis, the patient may have T1, a small tumor, N0, negative nodal involvement. But we know from our experience that even in those patients, you could develop stage 4 or metastatic disease 2 or 3 or 4 or 5 or 10 or 20 years later. I have a patient who had metastatic disease 28 years after their first diagnosis of breast cancer, which means there are some properties where these cancer cells lie dormant, lie hidden, and we have to find ways to kill it. We have to find ways to control this and prevent the development of metastatic disease. And that's what's defined by the use of adjuvant therapy, and that's the adjuvant systemic therapy. Sometimes that's based on chemotherapy, and sometimes that's based on hormonal-based therapy or targeted therapy. But nowadays, even before we operate, we are sometimes giving patients treatment before the surgery. That's called neoadjuvant systemic therapy. And then patients undergo surgery. And there's multiple advantages to doing that. One is quicker drug discovery and development. 2, it gives us the ability to prognosticate. What are the chances patient's cancer is going to come back or not? And the adjuvant therapy is where you're actually delivering systemic therapy to women who do not have metastatic or stage 4 therapy, and predominantly involves use of chemotherapy or use of hormonal therapy or anti-hormonal therapy. And we know that using both actually helps save lives. As you can see in the bottom part of the red curve, that's when patients got the chemo, and the upper part of the curve is when patients did not get the chemo. So you see how patients are, the disparity between these two, suggestive of the number of women you're curing from cancer coming back. So delivering chemotherapy, and in this case delivering tamoxifen to these women, we know saves life. But at the same time, we want to avoid toxicity of the treatment. T1, N0 breast cancer, that's a tiny tumor patients you see. With surgery, you got 80% cure. You're trying to make it 95% cure. And that's what we're doing with the systemic therapy. But in doing so, we actually give a lot of toxicity to that 80% of the women, right? Out of the 100, 80 people would get chemo for no reasons. They were already cured. And that's what is the big question, because you want to avoid over-treatment. You want to avoid toxicities in these women. And that's the focus in identifying patients who would not need chemotherapy, in identifying patients who would not need anti-hormonal therapy. And this is one of the key principles that we have understood in terms of managing breast cancer. 100 years ago, surgeons used to cut out the entire breast, cut out the lymph nodes, cut out the muscles, even the rib cage, thinking that the more extensive surgery you do, your chance of curing is better. But over the last 40 years, in fact, one surgeon made the difference. His name is Bernard Fisher. If anybody deserves a Nobel Prize, he's the guy. So he actually challenged the current dogma at that time, where resecting entire areas of tissue is important for cure. He challenged that dogma and said, breast cancer is not actually a local disease. It's actually a systemic disease. So it doesn't matter if you do a big surgery or not. The cancer is going to come back anyway. So you have to treat it as a systemic disease. And that's where this current dogma comes in, where we call, and I train my fellows in understanding this, where we call biology actually trumps anatomy. So you could have a T3N2 cancer. That's a tumor that's actually 7 centimeter size, a tumor that's involving a lot of lymph nodes. You don't necessarily have to do chemo and hormonal therapy and this and that for those patients. You don't necessarily have to do large morbid surgeries to those patients, because we know that anatomy is actually sort of pointless and biology is what's important. But when I speak about biology being more important, what are ways we can understand the biology of a cancer? There's two kinds of factors that we can use. One is called prognostic factors. And prognostic factors are when we actually understand the prognosis of a person's cancer. Is it good prognosis? Is it bad prognosis? Predictive factors are factors which we can use to determine the treatment that we can deliver to that patient. So in terms of prognostic factors, we know that nodal status is bad. if a patient has N2 or N3 disease involving lymph nodes in the neck from the breast, disease involving lymph nodes right in the middle of your chest, those are bad. Those patients have a higher chance of cancer coming back in the liver or lungs or bones versus somebody who has no lymph node involvement. So that's what it means by prognostic factor. Tumor size is important. It's common sense. Anybody who have T3 cancer that's diagnosed late have a higher chance of cancer coming back compared to somebody who does not have T3, like T1 for instance. So that's another prognostic factor. Like that, we have a lot of prognostic factors we can use, but prognosis doesn't mean much for the patient sitting in front of you. They don't want to know about what their prognosis is. What they want to know is, what can I do to make things better for me, right? And that's where predictive factors come into play. And one of the predictive factors was HER2 receptor expression. We knew that HER2 receptor expression in breast cancer was bad prognosis. But until we identified a drug that can target those women who have HER2 positive breast cancer, it meant nothing to that patient. And once we identified Herceptin or trastuzumab, we were able to alter the bad prognosis and make it into a good prognosis. But what I'm going to focus my attention today is on multi-gene assays. In terms of deciding prognosis of a patient, there's various clinical prognosticators available, something called Adjuvant Online and something called Predict Online. These are tools where you can have it online tools based on age, based on ER status. You can sort of prognosticate high risk or low risk, and you can also predict what are the benefit of chemo. In this patient, for instance, the yellow is noted by the benefit of hormonal therapy, and the red is noted by the benefit of chemotherapy. So you can show in a graphical representation that patient could have good prediction in terms of getting chemotherapy or hormonal therapy. But these are clinical prognosticators. You can only use this in clinical matter. But we know that clinical tools aren't the best. They are not completely useless. This is grade 1, grade 2, and grade 3. And as you can see, you can chart out a nice 3-point curve using grade 1, grade 2, and grade 3 in terms of prognosis, grade 3 being the worst prognosis. So it's not entirely useless, but we know that the reliability of tumor grade is not great. If independently, if investigators or pathologists rate or grade these tumors, there's a wide variety of inter-observer variability. And so it's not entirely useful, but it's not entirely useless too. So just having such clinical information doesn't mean much in today's world. And that's where we use multi-gene assays to help prognosticate, but more importantly, to help predict. Now, here's where I'm going to talk about the various multi-gene assays that we have at our disposal. And the first one that came into market was something called the 21-gene assay, or otherwise called the Oncotype DX assay. And this was developed from about 250 genes identified from the literature based on knowledge available in the early part of 2000s. And using gene expression profiling, they were able to identify 16 cancer genes and 5 library reference genes. And using regression modeling, they were able to categorize these patients or these tumors for each patient into low risk or intermediate risk or high risk based on a score of 0 to 100. So patients who have what we call recurrence score of less than 18 would be low risk. Anywhere above 31 will be high risk. And how do we know about this? Using a very important clinical trial called NSABP-B20 trial, where patients got chemotherapy or no chemotherapy. Everybody got hormonal therapy. We figured out that those who have a higher recurrence score have a higher chance of distant recurrence. So more likelihood of having stage 4 disease, even if they were stage 1, 2, or 3 at the time of diagnosis. Those who have low recurrence score on the other side of the curve, they have very low likelihood of distant recurrence or stage 4 disease. And in terms of benefit from chemotherapy, those who have low scores, the green ones, actually even if you do chemo or not, it doesn't test the statistical test of using the thumb rule. Can you place a thumb in between? That's my statistical test. Then it's not useful, right? Whereas in terms of high recurrence score, this is the red is where you get chemo, and the other one is not chemo. Clearly, it fills the statistical thumb rule, where if patients have high recurrence score, you can give them chemo, and there is significant benefit in reducing your risk of recurrence, okay? And that's where this test becomes very important. But we knew that in the setting of lymph node negative disease. What about lymph node positive disease? Using an old clinical trial of chemo versus no chemo in patients with node positive, that's lymph node positive, N1, N2 disease. Well, actually N1 disease. Kathy Albin and a team from Chicago were able to replicate the same result in node negatives and show that in patients who have high recurrence score, you are able to predict those patients who will benefit from chemo versus those who have low recurrence score, they don't need more chemo. Okay, so that's basically the sense of the Oncotype DX test. Now, how important is this? As you can see, the y-axis is actually Oncotype score, and the left axis is various factors. For instance, the panel on the extreme end is age. As age goes higher, the prevalence of low Oncotype scores are higher. That means older age breast cancers seem to be more indolent, seem to be more less, lower risk for recurrence. Whereas younger age, the far extreme, actually have the Oncotype scores are running all over that curve, all over that y-axis, which means you really can't use age as a factor to determine what the Oncotype score is. Even if you come to the grade, the bottom panels, all three are grades rated by 3 different pathologists. So if, let's say, pathologist FJR on this extreme end, if that person actually called one of those tumors, one of those dots as poor risk, if you look at it, that patient actually has low Oncotype recurrence score. So this shows that Oncotype score or 21 gene assay has a very independent prognostic ability and predictive ability more than the clinical and pathological factors that were in existence and currently used even now. But the problem with the 21 gene assay or the Oncotype DX assay is a lot of out of the 16 genes that we measure, the most weightage is on the HER2, the HER2 protein, the ER protein, and the proliferation group. Now these are actually easily measured on pathology. So if a good pathologist measures it, if a good pathologist estimates it, is he able to replicate a genomic tool? And this question was explored by my previous institution, McGee Hospital and University of Pittsburgh, and they came up with the McGee equation, and basically they abstracted information from our UPMC records and used the ER, PR, HER2, and the Ki67, and they were able to actually very easily predict the Oncotype DX scores without too much trouble. So in patients with actually, if this is the Oncotype DX scores, and this is what the McGee is predicting. So the McGee score using regression coefficient is predicting a 19, and the actual Oncotype score was 20. So it's even a good pathologist can actually more or less predict, with not great certainty, but reasonable certainty, the genomically obtained tool. Now, this is important in a country like India where we don't have access to these tissues, access to these tests. So this is open access. We can actually plug in the ER, PR, HER2, tumor size, and the Ki67 percentage, and it will churn out 3 various predictions of an Oncotype score. And this was published in Modern Pathology. And so that's insufficient. So that's the trouble with Oncotype DX score. It actually gives us what we can already obtain from a common pathology. If the pathologist is good and competent, he's able to sort of predict the genomically obtained tool. So that's insufficient, right? That's not actually what we want to obtain from a genomic tool. And that's where 2 other companies come into play, Mammaprint and Pam50. And Mammaprint is a 70 gene assay obtained from an unsupervised analysis of 25,000 genes, and they actually, using a clinical trial where patients did not get any adjuvant therapy, they were able to identify patients who had distant metastatic disease at up to year 20, and those who did not develop distant metastatic disease, and they identified top 70 genes that were able to classify those patients into whether they got metastasis, denoted by the white bars, versus those who did not get the metastasis, denoted by the black bars. And the farther extreme, the good signature, and the lower is a poor signature. So this is how the Mammaprint test was identified using 70 gene expression profiling. And at that time, they did not know where in the pathways of cancer metastasis does these 70 genes fall into play. But since then, they have sort of figured out where all these genes actually matter. But initially, this was independent of our current knowledge. Now, is Mammaprint good? In terms of retrospective studies, stored tissue samples from clinical trials, they were able to find that patients who had low risk of Mammaprint actually have no benefit from chemo. Low risk of Mammaprint, again, that's a distant metastasis-free survival. This is breast cancer-specific survival. Basically, no benefit for adding chemo in low-risk patients. What about in high-risk patients? Again, this one stands the test of thumb rule. The other one did not. If you can see that, I can't even place a thumb in between there. But this one, clearly, if patients have high-risk Mammaprint, their likelihood of not having stage 4 disease without chemo is 88%, and with chemo, you're bringing, 76%, and with chemo, you're bringing it up to 88%. So you are actually saving 12 additional women out of 100. You see that? So out of every 100 women you treat in this high-risk cohort, because of giving chemo, you're saving 12 more women out of every 100 from getting stage 4 disease. So in high-risk patients, in the small retrospective analysis of a clinical trial, they sort of proved the principle that they were able to not just prognosticate, but also predict for benefit of chemo. And they again did this test in lymph node positive patients, and again found that that's also a good prognosticator. But the Pam50 is another test that uses intrinsic molecular subtypes. And intrinsic molecular subtypes is basically using gene expression profiling. You're trying to identify the pathways which are more active. And you can sort of group them into luminal, which are driven by estrogen pathway, HER2-driven, HER2-enriched, which are driven by HER2 pathway, and basal, driven by neither of them. And this sort of replicates what I was talking about in terms of a clinical definition of the aggressiveness of the tumor. And these are the various types of intrinsic subtypes identified by Solly et al. In Vanderbilt. And using this tool, they identified another 46 genes from the entire, I think, 100 gene profile. And we're able to develop an assay called the Pam50, which again used a regression coefficient to come up with the score based on 0 to 100. And they validated this in 2 good clinical trials called the TRANSACT trial and the ABCSG-A trial. And we're able to identify patients, prognostic patients, at low risk of recurrence, intermediate risk of recurrence, or high risk of recurrence, okay, in terms of distant metastatic disease. So here's another test that was able to prognostic. So now we have looked at Oncotype DX test, that's a 21 gene assay, the 70 gene assay, or the Mammaprint test, and the Pam50, which is another risk of recurrence score. The problem with the risk of recurrence score, it's not an entirely genetically, genomically driven test. It incorporates the age of the patient, and it incorporates the Nottingham score, which is another measure of grade of the tumor. So it is not an independent test like we want it to be. That's the other problem with the Pam50 test. But if you look at all these 3 tests in terms of comparison of what genes they have, there's very little matching between, let's say, between the 70 gene assay and the 21 gene assay. There's just one gene actually that's common between the two. The Prosigna or the Pam50, there's very little that actually overlaps in all these 3 tests. In fact, one of the recent papers looked at Mammaprint, that's a 70 gene assay, and the Oncotype DX, that's a 21 gene assay, in patients who have the intermediate risk of Oncotype. If your Oncotype score is between that low risk and the high risk, what would their Mammaprint score be? So on the y-axis is the various oncotype score. That's a 21 gene assay in the intermediate risk. And on the x-axis is the 70 gene assay. The farther the scores, the lower the risk of cancer coming back. On the x-axis to the -1 is actually higher risk of breast cancer coming back. So using this test, the investigators were able to further delineate all those intermediate risk patients into high risk and low risk. Another problem, it's not just recurrence within 5 years that's a trouble. We know from large data sets that patients could have late recurrence. Like I said, patients with the hormone receptor positive disease can have cancer coming back 20 years later. As you can see from this graph, at year 20, if patients had N4, that's 4 to 9 nodes with cancer, 52% of those patients have distant recurrence. That's dramatic. That's pretty huge. Now, are there tests that you can use to identify patients who have a later risk of recurrence? If you have access to those tests, we can actually use it in clinical practice in extending the duration of hormonal therapy. You can give patients more hormonal therapy, and that actually has been shown in certain trials to help save more lives from breast cancer recurrence. Now, without the access to such genomic tests, I can use stage at diagnosis to determine if patients need long-term anti-hormonal therapy. I can decide if stage 3 patient, I think I can say you definitely need to be on hormonal therapy for a long term. But what matters more is identifying a biomarker for late recurrence. And there's multiple biomarkers as noted by gene expression assays that's available. One such test is the breast cancer index. There's another one that's just upcoming. It's called the EndoPredict. Oncotype DX is also a test that's in this space. The Prosigna, the risk of recurrence score, like we talked about for the chemo, also have the hormonal therapy approach too. But in terms of breast cancer index, it actually uses 2 genes, the expression of HOXB13 to IL-17B ratio, which is an important player in estrogen receptor pathway, along with a 5-gene profile called the molecular grade index. And using this test, the investigators were able to prognosticate those patients who were at a higher risk of late recurrence. I'm not talking about 5 years, but beyond the 5 years. So this is another tool that we have and FDA approved for use in patients in breast cancer clinic to decide if they need extended endocrine therapy, if they have a low risk, intermediate risk, or high risk. But I talked about a lot of these tools being tested retrospectively. Now that's not enough. It's not enough that we test tools in retrospective clinical trials. We want to test it prospectively because we know that there could be a lot of biases that could impact your analysis. So prospective validation is the most important tool that we use as oncologists to determine if we need to use a particular gene expression test or not. And that's why the Oncotype DX company actually promoted this trial called the TAILOR-RX trial. And this TAILOR-RX trial uses 11,000 ER positive patients, lymph node negative patients, and Oncotype DX's assay is done at the get-go. If patients have low risk of cancer coming back, that's a recurrence score of less than 11, they just get hormonal therapy. If they have high risk of recurrence, they get chemotherapy plus hormonal therapy. If they have intermediate risk of recurrence, that's where we really do not know whether chemotherapy is helpful or not. That's where those patients are randomized to getting just hormonal therapy or getting hormonal therapy and chemotherapy. Now the last column there, that's the arm A, where patients only got hormonal therapy, that actually is currently available. That result was published 2 years ago. It was not randomized, but it gave us further prospective data that shows that if patient has low risk Oncotype DX score, their risk of distant metastasis-free interval, that's at 5 years and beyond, almost 98 to 99% of patients did not have recurrence. So this gives us more confidence in this test. Okay, retrospective study is not important. This prospective study gives us more confidence that if a patient's Oncotype DX score is less than 11, you can tell that women that their prognosis of having cancer coming back distally is excellent. 99 out of 100 did not have distant recurrence. If you look at this bottom part, this part, the risk of recurrence between 11 to 25, where patients are randomized to chemo versus no chemo, that trial is currently available, and we know that they're going to present it as a plenary presentation in June in the ASCO meeting. So this part will sort of determine what test we will use in our clinical practice, whether we're going to go with the Oncotype score for this kind of a population or not. So this is going to be a very keenly watched plenary presentation at our conference. But in terms of node positive women, patients who have N1 disease, the Oncotype DX has collaborated with the Southwest Oncology Group and conducted a large clinical trial. The results will only be available in 2023. More time needed. But the MINDAC, the Mammaprint, that's a 70 gene assay, actually conducted a very large clinical trial. And what they did, which was very fancy, was they actually assessed the clinical risk. For a doctor, there's ways we can determine if a patient's risk is high or low. So if I determine that patient's risk is high, then the company would measure the Mammaprint, the 70 gene score. If the 70 gene score shows that patient's risk is low, should we give chemo or not? I determine that patient's risk is high clinically, but the gene expression profiling says that the risk is low. What should I do? And that test was, that clinical trial was conducted, and the results actually was published a year ago. And what that showed was, in terms of patients who have low risk genomically, even if a doctor decides that patient has high clinical risk, their 5-year metastasis-free interval is like 97.6 in clinical low and genomic low. And in terms of high genomic risk, is about 92%, 92.8%. So that's the 94.7%, the 5-year distant metastasis-free interval. So this is another prospective validation of the 70 gene assay that looked at patients with breast cancer, which are T1, T2, N0, or N1. Those patients who a doctor thinks have a clinically high risk, if their Mammaprint comes back as low risk, you could safely omit chemo. Now, after this test actually came back, our ASCO, American Society of Clinical Oncology, actually gave this test a grade 1 approval, basically because this is prospectively done. Now let me give you an example from my clinic. 44-year-old women who have T2 N1 cancer, that means the tumor is about 2 to 5 centimeter in size. N1 when the cancer has gone to 1 or 2 or 3 lymph nodes, not more than that. Strongly ER and PR positive, 95% of the cells stain intensely for ER and PR. And grade 2. Is that one of the famous California earthquakes? And grade 2 disease. So that's basically grade 1, 2, 3, the middle, right in the middle, grade 2 disease, and Nottingham score of 7. That again is not the highest of Nottingham score. Highest is 9, and the lowest is 5 or 6. So right in the middle. If this patient came to me 5 years ago, I would say, T2, N1, you're young, you have intermediate grade cancer, grade 2, it could be grade 3, who knows, Nottingham score 7, I think you need chemo. Okay. Now, in today's world, I would order a Mammaprint because I have already estimated this patient's risk as high risk. And what did the Mammaprint show for this patient? It came back as low risk. So then I can actually sit with the patient and have a discussion. Okay. Your clinical risk is high, but your genomic risk is actually low, which means in clinical trial that was done prospectively, 94% of patients did well without chemo. If you get chemo, maybe we can get that number to 95%. Does that 1% matter to you? You can have that discussion, a shared discussion. So you see how that the discussion is actually getting from a clinical assessment of risk to actually a tool using genomics in an actual oncologist clinic and actually having a discussion based on risk and benefit. Another case, 57, T2N1. Now 2 out of 18 lymph nodes were assessed and 2 had cancer. ER and PR are strong. HER2 is negative. Grade 2. Nottingham score is 7. If this patient sits with me in my clinic 5 years ago, I would say, I think your risk is quite high. I don't know how high, but I think you would need chemo because 2 out of 18 lymph nodes have cancer. That means there must have been at least one cancer cell hiding somewhere in liver or lungs or somewhere else that could grow to give us trouble. But what I can't tell the patient is your treatment, best treatment, hormonal therapy, or should we add chemo also? Because that I don't know. I have a hunch because the hormone expression ER and the PR are both 95%. My hunch is this patient probably doesn't need chemo. This patient's best systemic therapy is hormonal therapy. But then I would leave it there and say current practice guidelines is to give chemo. But today I can order genomic testing, and what did it show? It showed that the patients, despite the fact that my hunch said ER and PR being high, 95, 95, my hunch saying that chemo is probably not going to be, I didn't know the test results, but I forgot about what so I was actually playing it real with you guys. So my hunch would have been, I don't think you need chemo because your ER and PR is so high, hormonal therapy is good. But now look at that. I mean, I ordered this genomic testing and it came back as high risk. So for this woman, I can say without chemo, there is a higher chance of your cancer coming back. So I think you would need chemo, right? So that's another way it helps in my clinical practice. I actually forgot the answers to all of these actually, so I'll play it real with you guys. So case 3, 61-year-old, T1C, that's a tiny tumor again, between less than 2 centimeter, 1 out of 1 lymph node, so only 1 was assessed, that's the practice now. ER and PR 80% cell sustaining, HER2 negative, grade 2, Nottingham score 7. In this patient I would say, you're 61, in good shape, ER and PR are not very strong, grade 2, Nottingham score 7, I think you would benefit from chemo. I think your biology is a luminal B kind of picture where it's probably a slightly higher grade. I think you would need chemo. But then I can order genomic assay, and I was correct, but high risk, in terms of, so she would need chemo. Case 4, T2N0, no lymph nodes involved, which means great prognosis. ER 90, PR 70, HER2 3+. So now this patient has HER2 positive cancer. Grade 3, Nottingham score 9, so high grade actually. So today I would sit with this patient in India, for instance, where I do not have access to test. Well, I do have access to this, it's just too exorbitantly expensive. In Indian value, it's around 2.2 lakh rupees. I would sit with this patient and say, hey, I think I would need to do this test. I would need to give you chemo, but we do the genomic testing and it comes back as low risk. So then I can actually sit with the patient and explain that with chemo or without chemo, you stand to benefit probably 1%. In terms of 1%, how would that number matter? We have this tool called number needed to treat. So 1% implies I have to treat 100 women with chemo to save 1 woman from getting distant disease. That means 99 out of the 100 got chemo needlessly. You understand? So the number needed to treat is 1%, whereas in high-risk disease, it could be 20. 20 number needed to treat could be 20. Number needed to treat could be 10. So essentially, this gives me an extra tool. Now, last case, 42 T1C N3, 11 out of 22 lymph nodes were cancer. ER/PR strongly positive, HER2 negative, grade 2, Nottingham score 7. High-risk cancer, a lot of cancer, N3 disease. Ordinarily, you should not order Mammaprint in this patient because the clinical trial called the MINDAC trial looked at only patients who were node negative and nodes with 1, 2, 3 involvements, not 11 nodes involvement. But this patient came to my clinic, she was 42, and said, Doc, I do not want chemo. I do not want chemo. Give me one reason and can you do something that tells me that I should not need chemo? Because she wanted to keep her hair. And I told her, it'll be out of the window to do this test for you because it's not done in patients with 11 lymph node involvement. But I know that biology trumps anatomy. Regardless of whether there's so much lymph nodes involved, I know that anatomy doesn't really matter much. I know it's the biology. And I know that chemo for this patient may not mean much if the biology of the cancer is slow growing. then the best treatment for that patient is anti-hormonal therapy. And so I had a great, big, long 2-hour discussion over a couple of days. And the patient demanded this test to be done, and I documented everything for my own safety. And I tested, and she was right, and I was right. It was low-risk disease. She did not need chemotherapy, and I actually put her on a clinical trial using something called palbociclib. It's a drug in cell cycle inhibitor. So she was right. Biology actually trumps anatomy, and that's proven in all of these tests. Okay. And that's where the genomic assay is currently used in clinical practice. Now, where are we going in terms of systemic therapy? This is an editorial I wrote for the trial that did not use chemotherapy at all. So in this trial, all the patients had their tumor subtyped using gene expression profiling and identify their intrinsic subtype. So patients who were HER2 enriched, they just got HER2 targeted therapy. That means trastuzumab. They did not get chemotherapy at all. And after getting trastuzumab, when we do the surgery, 40 out of 100 patients did not have any cancer cells left behind. Okay, that means you actually managed to kill it without even chemo. So that's where the field is moving. The field is moving to a stage where we are actually trying to determine the intrinsic subtype of the tumor. And like it said, we started with the histologic subtypes, we moved to clinical subtypes, molecular subtypes, and now we are actually moving to multiple genomic subtypes in the management of breast cancer. If a patient has stage 4 disease, I change my focus of attention from cure. There's no way I can cure. Well, that's not entirely true. I have patients who are free of living with metastatic cancer 13, 15 years now. So there are exceptional responders, and that's one of the exciting areas of research where we are actually doing whole genome sequencing and exceptional responders, trying to figure out what actually is making them exceptionally responding to treatment. But the idea is you are focusing your attention on palliation and not curation. And in this setting, does genomic testing play a role? In the TCGA assay, you see that there's a lot of genomic alterations in breast cancer. There are ways you can target some of these, but we really don't know much about metastatic disease because these were primary breast cancer specimens. And that's where the NCI collaborated with a lot of us in doing a big trial called the MATCH trial, which some of you may have heard about. And MATCH trial is something called a basket trial, where patients are put into various baskets, not based on their tumor site of origin, but based on their mutation. So a patient with lung cancer could actually be treated same way as a patient with breast cancer if they have cyclin D1 amplification using a drug called palbociclib. The same way, a patient with breast cancer could be treated the same way as you treat a patient with lung cancer if they have ALK fusion alteration and get the same medicine for that. So that's something called the basket trial. And these are the various drugs we are using in this trial for various alterations. And as of last year, 4,000 patients, nearly 5,000 patients were screened for this trial. Only about 10% of patients had some genomic alteration that we could target, and breast cancer was not one of those important ones. In terms of next-gen sequencing for genomic tools, we can use tumor tissue biopsy and cell-free DNA assay. Liquid biopsy is something that we use very often in clinical practice. Various companies actually provide this, not clinically validated, but one of the companies that I use is Guardant liquid biopsy testing. It's using cell-free DNA to estimate some mutations that we always have to check again with the tumor tissue biopsy because we find that there's a lot of discordance between what we find on cell-free DNA testing and tumor tissue biopsy for various reasons. In fact, even if you use the cell-free DNA testing in 2 different companies, we get different gene profiling. So it's a mess right now, but we still use it in some ways. I'll tell you one of the reasons why it's important, and that is called ESR1 mutation. Now, ESR1 mutation is the estrogen receptor itself, and that gene got mutated, and patients have constitutively active estrogen pathway. And it's not commonly seen in primary breast cancer, and this sort of develops in terms of treatment resistance. As you get a lot of anti-estrogen therapy, your chance of getting this mutation grows higher. The average prevalence of ESR1 mutation in metastatic breast cancer is about 20%. And in terms of clinical trials, we have found that regardless of whether they have ESR1 mutation or wild type mutation, some of the treatment make no difference. But if they have ESR1 mutation, that means the prognosis is poor. So I use cell-free DNA testing to identify ESR1 mutation, primarily to help me prognosticate in a woman, are you going to do bad or good, and also to help me decide should I switch treatment to something that actually goes beyond the pathway itself. And these drugs are it's the CDK4/6 inhibitors, otherwise called the palbociclib. And if you look at a trial using palbociclib, the blue line is those patients who got the palbociclib, and the yellow is those who did not get palbociclib. Regardless of whether ESR1 is mutated or whether they have wild type, that drug seems to be quite effective. So that's where I'm currently using this test, or cell-free DNA testing, in clinical practice in stage 4 cancer patients to help me decide what kind of treatment to use in patients. And in terms of ESR1 mutation, we are identifying more fusion proteins, which also have the same role of constitutive activation. And all of this is very important in clinical practice. Now, thanks to all of these genomic tools, I can actually determine who would benefit from chemotherapy, who would not benefit from chemotherapy. But what's more important is getting more data in prospective cohorts, because we know from prior experiences that retrospective cohorts can give you a lot of false signals. And some of these companies have endeavored to do those prospective cohorts, the Mammaprint being one instance. The Oncotype DX will present their results shortly. And as we have more data in prospective manner, our confidence in these tests also increase significantly. And more importantly, in breast cancer, immunotherapy has really no role currently. But could we identify those subsets of patients who have, for instance, a higher tumor mutation burden as one biomarker who you can give immunotherapy? We just do not know. So this is sort of a very broad eagle's eye picture view of how I use some of the things that you think about, you work on, you debate about and read about and